your choice. I am Dr. Roopnarine, and we're coming to you live from our studios here at ACTN. On tonight's program, we'll be discussing the field of neurosurgery. With me in studio tonight is consultant neurosurgeon Dr. Narinda Ramnarine. Dr. Ramnarine is a consultant at the San Fernando General Hospital, and he also has offices at the Southern Medical Center and Medical Associates Hospitals. As usual tonight, guys, our number should come up at the bottom of your screens, and we'll do our very best to answer each and every one of your questions during the program. So guys, it's a very interesting topic tonight. It's all about neurosurgery, and with me in studio tonight is Dr. Ramnarine. So guys, let's say hello to Dr. Narinda Ramnarine. Doc, hello. Welcome to the program. Welcome to Your Health, Your Choice. It's a pleasure to have you.
Thank you for having me.
All right, Narinda. So Doc, I think when myself and yourself were chatting about the program,
yes.
We've been chatting for a long while now about you coming on, but just logistically it's been really hard.
Yes.
One of the main messages, one of the main things that you wanted to deliver to the audience out there, to the people of Trinidad, is about stroke.
Yes,
stroke, yeah.
Definitely.
So, stroke is a little topic that might have a little bit of movement between a neurologist and a neurosurgeon, right? But if you could just talk to our people out there, tell them a little bit about stroke, and tell them what can modern neurosurgery do for them.
Sure.
All right, docs, if you could just start firstly with just tell us a little bit about stroke, how it's treated, and then you could go into your specific field about neurosurgery and what's the modern developments in neurosurgery and how it improves outcomes for people who suffer from this problem.
Okay, so stroke in plain simple language is when you have the brain starved of oxygen for whatever reason.
Yeah.
Now, basically there are two types of strokes. There's ischemic stroke where the blood supply is cut off, and then there's something called a hemorrhagic stroke where there's actually bleeding in the brain or around the brain.
Yeah.
So first of all, we could deal with the ischemic part of strokes, which is where the neurologist more or less comes in play with that.
Right.
So that's where the blood supply is blocked and the brain is starved of oxygen. Good. Now, ischemic strokes, as well as hemorrhagic strokes, presents, in simply put, in an acronym, FAST. Okay. Right? That's a simple way to remember the signs and symptoms of a stroke.
Right.
So FAST meaning face, you get facial drooping.
Yeah.
A for arms, you get weakness of the arms.
Yeah.
S for speech, so you get difficulty in speaking. And then the last thing is time, meaning that time is of essence.
Right.
You need to get to a facility as quickly as possible so then we could get you treated.
All right. So, and from my point as a GP talking to the community, I suppose the main, I heard the acronym, it's fantastic, but I mean, what really happens is sometimes the patient begins to slur their speech.
Yes.
And sometimes they might lose power in a limb.
Yes.
The hand might go dead.
Yes.
And I think that's like the typical phone call we get as GPs.
Yes.
They're struggling to speak, or they're speaking Thai tongue, and they're not sounding the same. Once a patient recognizes that, it's not to second guess themselves, they are correct. The person is slurring their speech. You know what I mean?
Yes.
And that's a sign of a stroke.
That's a sign of a stroke.
All right, so you can go on there, Doc.
The other things that could add in is balance or eye problems. So either blurry vision or difficulty focusing. But those are more subtle and a lot of times are missed.
Right.
Right? So once you get these symptoms, it's more than likely you're having a stroke.
Yeah.
Good. You need to get yourself to a facility where we could get you scanned and then determine whether it's a hemorrhage or it's an ischemic stroke. Okay. All right? Now, if it's deemed that you have an ischemic stroke, all right, then our job as doctors is to get that brain revascularized, meaning open back the blood supply as quickly as possible.
Right.
Right? The T for time means that time is of essence, and we always say in neurology or neurosurgery, time is brain. Yeah. So if you don't get treated quickly enough, more brain tissue dies.
Right. And when you say treated quickly enough, you mean get into a secondary hospital where there are neurosurgeons and neurologists.
And neurologists, right? And so if basically in terms of the management of ischemic strokes, if you get there within 4.5 hours of onset of the stroke,
Yeah.
there's a drug that they could administer to help break the clot down. That's called thrombolysis.
Right.
There are indications, contraindications, which I wouldn't get too much into.
Of course.
But basically, it's up to us to decide whether we could give you that drug or not.
Right. And you could call for your slides whenever you want.
Yeah, yeah. So,
you want to see you want to put up the slide?
yeah, so we could put up the...
So, Josh, if you could put up the slide on you fast.
Yes.
Just to re-emphasize it, because it's a key point for the population to know. Face drooping, arm weakness, speech difficulty, time to call 911. You can go on?
Right. You could move on. Right.
Yeah.
So that's the
So those are some of the symptoms again. Balance, eyes, face, arms, speech, and time. All right.
Good.
Thanks.
Good. So,
That's fine, Josh. Tell me.
right. So if you post 4.5 hours,
Yes.
that's where I will come in.
Right.
Basically, you may be a candidate for something called mechanical thrombectomy.
Right.
That's where I go puncture the blood vessel in the leg, go up into the head
Yeah.
with a tube,
Yeah.
and through that tube and a stent,
Yeah.
basically pull the clot out.
Right.
And it's called a mechanical thrombectomy. And it could be done up to 12 hours
Okay.
safely. Good. However, as I said, time is brain.
Right.
The longer you are from the onset of symptoms is the more damage you will have.
Right.
Good. So, as I keep saying, the faster you get to a facility is the faster we can
Right.
look at treatment.
I just want to clarify those timelines there, right? Because this is something the average person in the public might not know the timelines that they need. So you need to get to the, if the person presents to the secondary hospital within 4 hours of symptoms, they could receive something called thrombolysis,
Yes.
which is able to dissolve the clot
Yes.
in the brain and preserve brain function.
Yes.
Right. Beyond 4 hours and to 12 hours, what happens there?
That's where the mechanical thrombectomy, where a stent could be put up into the brain and the clot fished out.
Right. And that will preserve brain function
That
as
will
well.
preserve brain function,
All right, so the key message is get into a hospital before 12 hours at least.
at least.
Right. What happens after 12 hours?
No, after 12 hours and up to 24 hours, you can still have a thrombectomy done
Yeah.
if you meet certain criteria.
Yeah.
However, it is difficult at that point to really say how much function will be preserved.
Right.
And sometimes in helping us assess if she'll be a candidate, that's where MRI may be needed, or MR perfusion.
Okay. So let me ask you a question. How long has thrombolysis been in play for cerebral or brain problems, brain strokes?
For
20 years? 20
for about
years?
15 years.
And how long has the thrombolectomy
Has been
procedure?
in for about 15 years as well.
In Trinidad?
Not in Trinidad.
How long have you been doing it in Trinidad?
So it basically was started around 2014, 2015.
Okay.
So it's been around.
Right.
Right.
And this sort of I mean, I'm going to ask you what the question the general man at home would be asking: is this available in the hospital?
Not currently.
Right.
It's not available in the hospital, but
Right.
we are working to
Towards
get
it.
towards
Right.
getting it. Yeah.
All right. So always continuously improving.
Yes.
Which is fine. So, what is the data in terms of the outcome of the patient after having received this sort of intervention versus not receiving this intervention?
So not receiving the intervention more or less condemns you to 100% surety of having a deficit.
Right.
Having a deficit meaning that you're weak on one side of the body,
Yeah.
you walk with a limp, you have the inability to use the hand on the opposite side of the stroke,
Yeah.
right? The outcomes with thrombolysis or thrombectomy are pretty good. Basically, you're looking at between 30 to 60% major improvement in outcome.
Right.
When I say major improvement in outcome, back to where they can use their hand and use their legs, and they may walk a little bit with a limp, but it improves with time.
And physiotherapy, I
And
suppose.
physiotherapy.
Yeah.
Now, if you get treated really quickly,
Yeah.
I've had patients that I've treated with thrombectomies who left walking
Right.
and normal, right?
Same day?
About
Next day?
3 days
Yeah,
after.
2 days after they walk
Right,
out.
so it all depends on the timing
Right.
of how quickly
So
you get
this is a stroke that is due to a clot, a thrombotic stroke.
clot. Yes.
All right. And if you maybe just, for simplicity, just explain the factors that contribute to a thrombotic stroke.
Right. So,
I mean, it's more general medicine, but
so the major factor really is
because I suppose the ultimate treatment is prevention.
yes,
And if you could just tell them what causes it.
is usually atherosclerotic.
Okay.
Right.
Plaques.
So plaques build up in the neck.
Yeah.
Plaques build up in the blood vessels higher up into the brain.
Yeah.
Those are the common causes, and then there are clots, actually clots that are thrown off most commonly from the heart.
All right.
So if you have an abnormal heart rhythm and you have clot buildup in your heart, it shoots out and goes straight up to the brain.
So myself as a doctor, what you're describing, sometimes it seems like a little bit of overlap between neurosurgery and vascular surgery, right?
Yes.
So a lot of the plaque buildup could also be like in the carotid artery.
Yes.
Right? So sometimes we could sort of preventatively, people might have a ultrasound done of the carotid artery,
Carotids,
right?
exactly.
And there might be plaque buildup there. And is there a surgical solution to that? Do you do that
Yes,
surgical solution?
So there are carotid.
You understand the drift I get now?
Yes,
Yeah.
yes, definitely. So you could get that plaque treated by a vascular surgeon.
Right. Do you do it?
No, so I don't do the carotid arterectomies. But
Right.
yes, I have colleagues, very good colleagues
Who do that?
who would do that.
And that's a sort of help you prevent shooting off a clot later.
Exactly.
All right.
Right.
But I suppose in Trinidad, sometimes prevention is really, we try our best, but sometimes it goes haywire, and then people get sick, and that's why they want to get a treatment so that they wouldn't have a debilitating function afterwards. Right, so those are the ischemic strokes, right? But as just showed us earlier, there's also the hemorrhagic strokes.
Yes.
Right? So tell us about those.
So the hemorrhagic strokes are what are traditionally neurosurgical problems.
Right.
So if you have a bleed in the brain, which is called an intraparenchymal bleed, or you have a bleed on the surface of the brain or below the brain, those are usually neurosurgical problems.
Right, and you could only diagnose that with an MRI or a CT scan.
A CT scan.
A CT scan.
Right.
All right, so suppose as soon as the patient reaches the hospital, they get a CT scan.
Yes, so the first step really is to get a CT scan to make sure that it's not an ischemic, a hemorrhagic stroke. If it's not a hemorrhagic stroke, then you go down the pathway of an ischemic stroke. And
Which you just discussed there.
Yeah.
You could put up that slide there, Josh, in the meanwhile.
Yeah.
Is there any advice you could give to people, like, let's say I'm sitting at home and I started to do my speech, my hand drops. I don't know if it's an ischemic stroke, I don't know if it's a hemorrhagic stroke. Is there any medication that you tell the patients to use at home before they come to the hospital, or is it just get to the hospital?
No, I wouldn't advise taking any medication prior to getting that scan done.
Exactly.
Because if you have a hemorrhage and you take the blood thinners, which a lot of the population will commonly take, basically you could turn a small bleed into a massive bleed, and it then becomes life-threatening.
Right, so basically telling the patients, don't take aspirin.
Don't take aspirin.
Which is a common thing we always say, people say, take aspirin, take aspirin.
So,
you wanted to go through the management there of ischemic and hemorrhagic
well,
stroke?
that's fine.
That's fine.
So
right, so we reach the stage of the hemorrhagic strokes. Yeah.
So the hemorrhagic strokes that you commonly see is intraparenchymal bleeds.
Right.
And most of the time these are hypertensive bleeds with high blood pressure.
Right.
You have a ruptured blood vessel within the brain, and that causes a bleed within the brain itself.
Yeah.
Right. However, sometimes these bleeds could be because of something that we'll discuss further in the topic, which is aneurysms or vascular malformations.
Very important for us to discuss later on tonight.
And then the other types of bleed that you could get is a bleed on the surface of the brain, which is called a subdural hemorrhage.
Okay.
Very common in the elderly population following minor trauma.
Right.
And they present with stroke-like symptoms, weakness, slurring of speech, difficulty with balance. Right.
A subdural hemorrhage.
A subdural hemorrhage.
And that's usually after trauma, falling down or something.
Falling down. Right. Usually mild trauma in the elderly. And they start having these symptoms, you come in and you get a scan, you realize.
And I suppose the important thing for the doctors, in the community doctors and community people to understand is that sometimes this might not happen right away in a subdural.
In a subdural, it more commonly happens delayed.
Exactly.
So there's an initial bleed, it stops, then there's a second bleed, it will stop, and then they only present when it gets to a major size.
Yeah. And they only show symptoms that's what you mean, and they get a major size.
Yeah, and then you have to.
So, which is important that if granny or grandpa fall down, that you don't just watch them for that moment in time.
Yes.
But you actually watch them for up to 72 hours after.
Exactly.
Because a lot of stuff could happen 72 hours after. And that's sometimes very important to explain to patients.
Yes, and even after that 72 hours, if they find that they're complaining of headaches, even before they get weakness in the legs or slurring speech, if they're complaining of worsening headaches, they should go get a scan done.
Go and get a scan done.
Yeah.
Right, big point. It seems like if CT scans, well, maybe from the olden days, CT scans and MRIs, it seems like it was like really fancy, expensive tests to get, right? But the reality nowadays in modern medicine is that these things are not. These are first-line investigations nowadays.
Yes.
And it's very important for the population to understand that too.
Yes.
I think for headaches, yes, we have great clinical skills.
Yes.
And we could determine and we could see whether you're in trouble or not. But I think we really need to be moving towards CT scans for people who having a lot of headache. They really need to get a CT scan and not delay it.
Although we have guidelines on use of CT scans and stuff, as long as you present to me for a headache, meaning that you're worried enough about that headache to come to me, you get a scan.
Exactly.
Right? Because it means even if the best thing that it could do is show that there isn't anything there.
Exactly. And you can live your life happy.
Exactly.
All right, Doc, so this is a good time for us to take a little break. And when we come back, we'll continue on a little bit about the hemorrhagic stroke, and then we'll get into the aneurysms after, okay?
Sure.
All right, guys, so I'm here with Dr. Narinda Ramnarine. He's a consultant neurosurgeon. I'd just like to formally invite you to send in your questions and comments to us, and Dr. Ramnarine will do his very best to answer them. All right, guys, so we'll see you back in one moment.
Growing up, I was convinced my great Aunt Lillian was a fairy. She had this way of just knowing when two people belonged together. And all I've ever wanted was to be truly in love.
Him? Really? He's a cynical snob with absolutely no filter.
What are you? And he hates Christmas.
It's all boxed gingerbread sets.
ACTN The Voice launches a new and versatile culinary series called Stacy's Kitchen.
Hi everyone, welcome to Stacy's Kitchen. And on today's episode of Stacy's Kitchen, we will be cooking up a Thanksgiving feast. Our rolls are ready and looking yummy. Nothing like a good curry chicken and some basmati rice. So I'm gonna start putting my wings in to fry.
We will showcase how to make tasty international cuisine with our local products. We emphasize meals on a budget with our selected ingredients.
Restez à l'écoute, Stacy's Cuisine. Au revoir.
So you can put how much, depends on how big you want it. So our fish is ready. Oh my God, look at that. Oh my God, oh my God. Just like paratha, this is lovely.
Join us on ACTN on Monday evenings at 6:30 p.m. Don't miss Stacy's Kitchen, exclusively on ACTN The Voice.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
All right, guys, welcome back. We're here with Dr. Ramnarine, consultant neurosurgeon. We're talking about strokes. So, Doc, just before we went to the break, we were talking about ischemic strokes, hemorrhagic strokes. You were giving us the timelines that people need to get into the hospital.
Yes.
You were telling us about the intervention that you could do and other neurosurgeons could do to remove the clot and let them have a good outcome, right? Not like traditionally if you didn't do it. You also told us about hemorrhagic strokes, which is a different type of strokes, which is traditional neurosurgical care. So you could just take us again, let's continue on from where you left off with the different types of hemorrhagic strokes and the treatment.
The hemorrhagic strokes, basically, as we were speaking about subdural. So if you have a subdural hematoma that's large enough and causing symptoms, you could have it evacuated, either with a couple of holes in the head or a small cut in the skull
Right.
to take the bone off.
Right.
It's a pretty simple, straightforward procedure.
Is that called a burr hole?
Burr hole,
All
a burr hole or a mini craniotomy, depending on what type of.
And that releases the blood
That releases the blood.
and
takes it-
reduces the pressure on the brain.
Exactly.
Right.
And then within a few days, they are allowed to go home.
Okay.
And basically, they get back to their life.
All right.
Right. The other type of stroke we spoke about was the intraparenchymal hemorrhage. So that's usually hypertensive.
Yeah.
And if it's a large intraparenchymal hemorrhage, which is basically life-threatening, we do have the ability to evacuate that clot, right? But the damage is already done to the brain, at least the primary damage.
All right. I think it might be remiss of me not to ask this question, but I should have asked it from the start. How common is this in Trinidad and Tobago?
It's very common. Basically,
The stroke in itself is very common.
it's very common because given our population.
Given our population.
Of
And how common is the bleeds or the hemorrhagic type stroke?
It's actually pretty common. I would say maybe on a daily basis we get a referral for hemorrhagic stroke.
And that's truly due to hypertension.
Usually due to hypertension.
So I guess this is bringing home the message of the GPs and the public health doctors about looking after your blood pressure.
Yes.
Because when you don't look after your blood pressure, unfortunately, it ends up to you doing surgery.
Yes.
Trying to save someone's brain.
Yes, exactly.
All right. So you could tell us some more about those hemorrhagic strokes.
Right. So the surgery for hemorrhagic strokes, the primary damage is already done, meaning that there is damage to the brain.
Right.
Our job in terms of the surgery basically is preventing what we call secondary injury from the swelling of the brain, which usually happens 24 to 48 hours after the initial.
Okay. Doc, you were telling us a bit about aneurysms as well.
Yes.
That could be contributing to the bleed.
Yes.
Can you tell us about the aneurysms? Because that's something that, I hate to say it like this, but commonly you hear about young people dropping down.
Yes.
I think, you think back about some people I know actually, who just suddenly collapsed on the road and died.
Yes.
And we realize it's an aneurysm, or they suddenly get severe headaches, they end up in the hospital, and you hear that they had an aneurysm and they died.
Yes.
Explain to us, what is this whole aneurysm concept?
Right.
And how could we prevent it, or look for it, or treat it, so we wouldn't collapse and die? And what do you do to help people who suffer from this problem?
Right. So aneurysms, in simple language, is basically a balloon off one of the blood vessels. So we could think of the blood vessel just like pipes. Pipes that bring blood or bring water to your house, basically. So it's a weak point in that pipe that balloons out, and when it gets to a certain size where it's thin, it ruptures and it bleeds. And yes, 30% of people who have a ruptured aneurysm basically never make it to hospital.
30%?
30%.
Right.
Of the 70% that get to hospital, 30% of those will probably die while they are in hospital with or without treatment.
Right.
All right, and that's just because it's sequelae of the aneurysm, which basically you get something called a subarachnoid hemorrhage, and it has a lot of effects on the brain. Good. So it's very important that we recognize aneurysmal bleeds and treat them as quickly as possible. Right.
But the aneurysm, it develops, I suppose you might have some that might be come about at birth, and you might have some that develop later on.
Yes.
Is there a role for, can we screen people in the population for aneurysm? Because if it basically tells me a condition that is basically 60% of people will die. Is it worthwhile screening everyone in the population with a CT scan? Or is it worthwhile that I say, well, look, I'm going to my private doctor, my private hospital, and I'm going to get a CT scan of my brain to make sure I don't have any aneurysm?
Yes. So no, there isn't a rule for screening the general population because the incidence of aneurysms are pretty low. While in some populations in the world it's as high as 25%, so 1 in 4 people have an aneurysm. In our population,
it's very low.
Very low. So you're looking at, on estimate, 1 in 15 to 1 in 20, at least looking at my anecdotal evidence from what we've treated so far. Right, so it is pretty low. However, screening comes in play if you have two first-degree relatives who have suffered from aneurysms. Right. So if you have two first-degree relatives that have had cerebral aneurysm, then yes, you have to get scanned.
All right. So, Doc, let's say you have a patient with really bad headaches. We send them for a CT scan. It shows this aneurysm, and we say, hey, Dr. Ramnarine, help this patient. What do you do?
Right. So the once the aneurysm is picked up, then it's my job to then decide if it's worthwhile treating. So if it's a small aneurysm, and we're looking at evidence-based medicine here. So in the anterior circulation, meaning to the front of the head, what we have from our evidence is basically small aneurysms, less than 5 millimeters, that is. Well, 7 millimeters is what they would say. Sometimes I'm a bit more aggressive, so once it reached past 5, I would treat. But 7 millimeters is the guidelines. Then you treat. That's for unruptured aneurysms. Right? So incidental aneurysms that are picked up in the anterior circulation, less than 7 millimeters, you can watch it for the while. Now, watch it don't mean you sit and you leave it for X amount of years before you decide. If you're going to routinely survey this aneurysm, you have to repeat the scan in at least 6 months' time. If there is a change in size, that aneurysm needs to be treated.
Right. How do you treat it?
So treatment of the aneurysms are two ways. It's endovascular, meaning through the blood vessel, where again I go through the blood vessel in the leg or in the wrist, go up into the brain with a tube and pack the aneurysm off with platinum coils. So that's called the coiling procedure. Right? And that's what we look at internationally as the gold standard to treatment, just because the risk...
Is that it there?
The slide before.
Okay, let's put up the other slide.
Yeah, so that's the coiling of the cerebral aneurysm. So it's looked at as the world standard because the other option of treating the aneurysm is surgical, where you cut part of the skull, go below the brain, and put on the titanium close clip, which is the second slide, the next slide. That's called the surgical clipping of the aneurysm. So those are the two ways we treat aneurysms. As I said, the coiling is the gold standard because the risk is less than the clipping.
Side effect problems.
Side effects, morbidity. Which sounds really bad.
No, but the patient will be thinking about that because you're operating on their brain. So, I mean.
But at the end of the day, when you look at percentage-wise, clipping carries about 3 to 6% risk of having a major stroke or dying during the procedure. Coiling carries a 1 to 3% risk. Right? So figure-wise, it's not horrible.
No, it's good.
And then there are specific indications for surgery over the coiling. So that's where my job comes in. I look at the aneurysm and I decide which is it better to do. Is it better to coil or is it better to clip? Of course, I take patient choice into consideration as well. But those are the two ways I would.
I suppose the majority of patients might say if you could coil it.
If you could coil it, coil it. Yes.
Right, so after you do that procedure on those patients, so basically we do this procedure to get rid of the aneurysm and to prevent that aneurysm from rupturing and there many patients dying. So we basically save a life there. This patient would not have any further problems again, and they go back to life as normal?
Yes, so that's the disadvantage with the coiling. There is a higher risk of recurrence with the coiling procedure than the clipping. And that's why I take all the
So those are patients with aneurysms, which lead to bleeds in the brain. Is there any other type of aneurysm, any other type of treatment of aneurysm that we need to know about?
No, so those are the two major ways. I mean, within the coiling procedure, there apart from coils, there's a fancy stent we use called a flow diverter. And
so that, I just want to move you totally away from stroke now. I think you really give a message there. And a lot of neurosurgeons are involved in treatment of patients, sometimes shared with the orthopedic doctors as well, with lower back pain. When does a patient with lower back pain, because it's a very common problem, right? Back pain is a tremendous burden on societies around the world. When does a patient with lower back pain need to see a neurosurgeon? And what can you do for them?
So yes, lower back pain makes up the bulk of any neurosurgical clinic in Trinidad because it's so prevalent.
Right.
All right, but where the neurosurgeon comes in, while we do assist in the non-surgical management, meaning tweaking of medication, physiotherapy, it really comes down to the surgical management. We are surgeons at the end of the day, so it's really to decide whether this patient will benefit from surgery or not.
Right.
Good. And that's where the neurosurgeon comes in.
Right.
And yes, it's...
But what condition in the back will need surgery?
So, this prolapse most commonly, right? As you get older, you get, in simple terms, arthritis, so spondylotic changes to the back.
Yeah.
And you get lumbar canal stenosis or foraminal stenosis. Those are the things that are commonly treated in the back. Right. And of course, there are other things like spinal injuries, so fractures and stuff. We will get involved with that.
Right, we'll discuss some of that later.
Right.
So the lower back pain, so basically you will assess them to see the cause.
Yes.
And then you would operate on them if there's a cause that needs surgical intervention. The most common surgical intervention is if slip disc, I suppose.
Slip disc. And as well as I said, spondylotic changes or arthritic changes.
And that's one older patient.
Yeah, the older population.
What do you do for the persons with slip disc? What is the operation? Right.
So there are several treatments available. The most common treatment is just a plain, simple discectomy, which could be done minimally invasive or microdiscectomies.
What is that?
It's basically
explain the medical term.
So it's a small cut. Sometimes it's done with an operating tube, so you're just left with about a 1 to 2 centimeter incision. You get down, take off a little bit of bone, little bit of the ligament around the area, and then you take the fragment of the disc out. So that's called a microdiscectomy. Right. Traditionally, what we did back in the day, and still do it, it's still a reasonable operation, is we make the cut a little bigger, take out a bit more bone on either side of the spine, basically, and take the disc out, essentially. Right. So that's the open discectomies.
Right.
Good.
And how does that affect the patient afterwards? The disc is non-functional anyway, or?
Well, that's the thing. This is why we deal with only really the fragment. Now, the disc, as I say to a lot of patients, it's like a gel sole in your shoe. Keeps height up and gives a little bit of movement. Now, if you were to take the entire disc out, basically the bones collapse on each other. Good. And the hole that the nerve comes out actually closes down.
Of course,
So if we're going to remove the entire disc, then you have to replace that disc. If you have to replace that disc, we have to do something called an interbody fusion, where you put a little cage filled with bone, which will keep the bones apart, keep the holes open, and then fuse the two bones together, which is a bigger procedure.
Is this common surgery in Trinidad?
Yes, very, very common.
Very common.
So spinal surgery is extremely common. And I mean, basically, there's nothing that...
It's not what, sorry?
There isn't any of the surgeries that are available away that isn't available here.
Right, and so it's very common. A lot of patients might be scared to have spinal surgery.
Yes.
I mean, that's what people might tell me in the practice. You know, the patients, I really don't want to go to a neurosurgeon. I do not want to have surgery. I'm scared of surgery. I'm scared that I become paralyzed after. That's the kind of question the average man will answer. How would you answer that question?
And that's the reality we have to deal with, is that most patients are afraid of having surgery, especially lower back surgery, because they're afraid of getting paralyzed. Now, at the lower back, getting paralyzed is almost impossible.
Impossible?
Yeah.
Okay, good.
So, yes, if one of the nerves are damaged, you could get weakness to part of the foot. But the risk of that happening is very, very, very low. Good. So
this is safe surgery.
It's safe surgery. And in Trinidad, everybody knows somebody who has spine surgery and can't walk again. I'm still yet to meet those patients. Right. As I say,
I suppose you need to do the physiotherapy afterwards.
Yes. So, well, all the patients that I've seen all walk out and go home, and they're doing well. So if you need spine surgery, and it's done for the right reasons, the outcomes are usually favorable.
Okay. I think that's an important message to put out there.
Yes.
Because of that fear.
Yes, it
And
is.
then it might be preventing somebody from getting treatment.
And
because they hear stories.
And moving on with their life.
And moving on with their life.
Basically.
What is sciatica exactly? Because you seem to have a lot of patients suffering from sciatica.
Right. So sciatica, in simple words, there's a nerve to the back, so the buttock area that comes down and shoots down the back of the leg. Called a sciatic
It's a common problem in general practice.
You get impingement of either a nerve root that goes into that nerve or the nerve, the sciatic nerve itself. And you get pain shooting down or radiating down the back of the leg. All right? That's simply sciatica. And yes, it can be due to disc prolapse, but sometimes it's due to other non-surgical causes.
Right.
Right? And that's where we differentiate between who will benefit from surgery and who wouldn't.
All right. So I know you're a surgeon, right? But is there any non-surgical, would you see a patient who, I mean, you're only going to see patients who need surgical intervention, or what non-surgical intervention can you try before they end up having surgery?
So I tend to
I'm asking a surgeon a non-surgical treatment.
Yes. So if I see a patient in the acute phase, I give them time to see if they will settle, meaning that I try non-conservative. Strong painkillers. Once we get on top of the pain, start on a course of physiotherapy and see if that helps. That's if the scan isn't horrible.
Okay.
If you have a tremendously large disc in the spine and you have symptoms of spinal canal stenosis or cauda equina or weakness of the legs already, then I would just go in for surgery. But yes, definitely if it's not bad, I give you a chance to settle on your own.
Okay, then. All right, so now it's a convenient time to take our second break, Doc.
Sure.
All right, guys, so we're here with Dr. Ramnarine. He's a consultant neurosurgeon. We're discussing back pain, we're discussing strokes. We're going to be discussing a little bit about aneurysms and brain tumors after the break. I just want to invite you again to send in your questions to Dr. Ramnarine. All right, guys.
I love you, Mom. Before you know it, I'll be back to tuck you in.
Don't try to be a hero. Maggie? She was on her way to a refugee camp.
We just talked to her this morning.
Nathan doesn't have a father or guardian listed.
He has me.
It appears as if the child is on his own.
I'm the only father he's ever known.
Believe in yourself, and anything is possible.
ACTN The Voice welcomes you to join us for our newest agricultural television series, Harvest.
Welcome to Harvest. We're doing it double again, north and south. This morning we start here in Brazil Village on Bethany Estate with Michael and Jacinta Milne.
You can look forward to a personalized tour around scenic Trinidad and Tobago, showcasing different agricultural practices and teaching us self-sustenance.
So Wendy, you're about to show me your bromeliad house.
Yes.
Oh, this is lovely.
This is what our customers refer to as the Mecca for bromeliads.
Explore the many ways to make your harvest right for you.
So our chicken coop is more or less built at a height whereby it's easy for us to go and just remove the wood shavings into our barrow.
Now, you don't plant out your seedlings, you buy the seedlings, right?
Yes, we purchase our seedlings.
Here we are on a not quite monocrop site, but we have rows of tomatoes, rows of sweet peppers, and then you have the Milne's polyculturing.
Join us every Tuesday at 6:30 p.m. Harvest, a new dimension in agriculture.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
right, guys, welcome back. We're here with Dr. Ramnarine, consultant neurosurgeon. Doc, I think Josh has a few questions coming in.
Yes.
So we'll go ahead and take the viewer feedback one time,
Sure,
right?
sure.
Yeah, Josh, you could start. If you are already on a blood thinner, are you likely to get a stroke? And if you do get a stroke, what is the likely outcome?
So, on a blood thinner, you can get a stroke.
Yeah, a blood thinner, so perhaps they mean aspirin?
Aspirin, basically. Yeah. Even with clopidogrel, you could get a stroke. But what it does is it decreases your chances of having an ischemic stroke.
Yeah.
Now, if you do get a hemorrhagic stroke, basically, you could get a bad hemorrhagic stroke
because you're on a blood thinner.
You're on a blood thinner.
Yeah, makes sense.
So common sense will be taken common. So yes, you can still have a stroke.
All right, Josh, let's host PC. Let's switch it off there and drop the next question. Right, is loss of memory an effect from a stroke? Doc?
It can be, but there are more common reasons to loss of memory. And one is basically, as you get older, you could get several different types of dementia. And if it is that you have worsening memory, yes, you can see a neurologist, and they can make an assessment whether you need a scan or not, and then we take it from there.
It brings up another issue. Should older patients we think have dementia, should they get a scan right away?
I think they should see a neurologist to start with, right? At least see their family doctor first.
Yeah.
From that point, they could start the initial assessment, and if they need be, they could see one of my neurology colleagues who would then do a formal assessment and decide whether.
So memory loss is not a common symptom of a stroke?
Not common.
It happens?
Yeah, it happens. All right, but it's not the first thing that you would notice.
How about long after the stroke? About, let's say they miss that let's say a month after a stroke, is memory loss part of it?
So if you have a major stroke to the front of the brain, it can affect memory, behavior, emotion.
Right, so I suppose in answering that question, you're saying memory loss is not part of the initial presentation of a stroke.
Yes.
But that's the first 12 hours or the first 3 days. Memory loss is not a common presentation initially, but the sequelae of a stroke, you may have memory loss later on.
Memory loss.
All right, cool. Josh, you can put up the next question, please. Can an epidural cause spinal pain in the future? What is the epidural, Doc?
So, epidural, I'm assuming they mean an epidural anesthetic. Yeah. So, not usually, right?
Do spinal surgeons use epidurals?
Yes.
For what reason?
So to give pain relief. It's one of the non-surgical treatments for back pain. Okay. So it's sometimes epidural can be tried if the patient isn't keen on surgery, or if the scan isn't horribly bad, meaning that there's not a lot of nerve root compression. Right? And yes, sometimes epidurals do also help in the elderly population that has arthritis or arthritic changes to the back.
Or might not be suitable candidates for surgery.
Might not be suitable candidates for surgery.
So I suppose the important answer to that question is that epidurals can actually be part of your arsenal as a doctor to help people with back pain.
But unlike an epidural anesthetic, this is an epidural steroid injection.
Epidural steroid.
And
all right, let's assume the patient talk about anesthetic like during childbirth and so on.
Yeah. So
unlikely
that you will get pain down the line from that. Right? It's very unlikely.
Okay, cool. Josh, any more feedback? Are strokes hereditary? That's a good question.
So strokes itself aren't hereditary, but the conditions that lead to a stroke are hereditary.
Exactly.
So diabetes, high blood pressure, all right, hypercholesterolemia.
Or aneurysms.
Or aneurysms can be hereditary.
Yeah.
So if your parents suffer from diabetes, high blood pressure, hypercholesterolemia, you need to just keep an eye on yourself, get checked out, make sure that all these factors are treated properly for us
to prevent another stroke
from
prevent a stroke from happening.
happening.
That's why we do all of this, prevent strokes and heart attacks.
Yes.
cardiovascular complications, arterial complications.
Exactly, and just
because they're all connected, isn't it, doctor?
Exactly. So the same thing that causes a heart attack is the same thing that causes an ischemic stroke.
Right,
so
in the brain.
In the brain.
And it also could cause problems in your lower limbs.
In the lower legs.
And in your arteries that supply your kidneys, everything.
Yes, everything.
It's all connected.
So if you don't get your diabetes or high blood pressure properly controlled, you're going to run into problems.
Okay. Any more there, Josh? How can stroke patients reduce spasticity? What is spasticity, doctor?
So spasticity basically is, in simple words, stiffness of the limbs.
Why does that happen?
And it happens because you have uninhibited contraction of the muscles. In a normal patient, you have inhibition of certain movements or certain contractions of the muscle. When those are cut off, basically you get the muscles contracting and not being opposed, and that's essentially what causes spasticity.
Right.
In a stroke patient that has spasticity, the first step is really aggressive physiotherapy.
Okay.
Limb exercises, stretching. Basically, sometimes they would use splints to get these done, right? Now, if the spasticity is not settling and it's inhibiting movement, then there are things like Botox that can be done, as well as there are surgical treatments as well, but those are way down the line.
All right. We received a question that Josh was just telling me. The question, the sort of genesis of the question is motor vehicle accidents. It's very common in Trinidad.
Yes.
People hitting the windscreen with their head.
Yes.
They get concussions. They get some maybe even bleeds, but a lot of concussions afterwards. Do you see a lot of patients who have been involved in motor vehicle accidents?
Yes, definitely.
And just tell us a little bit about that, because I don't think the public realizes sometimes when you see driving on the roads,
yes,
especially younger people maybe, they don't really understand what happens after you get in that car accident.
Yes.
I don't think people think down the line.
Yes.
Car accidents could destroy your life, not even take a life, but actually destroy your life as well. And tell us a little bit about that. What do you think about concussions and so on?
So traumatic brain injury in so is very, very common.
Yeah.
We see it, basically daily in the hospital we'll get patients. Now, if you get into a major motor vehicle accident and have damage to your brain, it's basically like having a stroke, because that part of the brain dies. Good. And I tell patients, brain, which is made up of nerves as well as spine, the spine isn't like skin. You get cut on your skin, it heals in 6 weeks' time, you never know you had a cut. When the nerves get damaged, they will die, right? You then have to rely on the surrounding areas to take up a bit of the work, and that's what may give you improvement. But the nerves that die is gone. There's nothing we can do about that. So when you get a severe traumatic brain injury, the damage is done already. Everything else is to prevent, as I said with the hemorrhagic strokes, is to prevent secondary injury. Now,
so that's a traumatic brain injury that bleeds?
That bleeds, or even if you just have, when you have a contusion, it's a traumatic brain injury where you have a bleed within the brain. Right? And we see those very commonly, and it is damage to the brain. And part of the brain does die.
And we just hope for the best outcome.
Yes, and after that, again, that's where rehabilitation is required. Once you get past the part of if needing surgery and the patient is alive, rehabilitation is what is needed. And proper neurorehabilitation is needed in a lot of the cases. Right? And
is it available in Trinidad?
Some of it is, some of it isn't. We're working to try to get things up to speed with the neurorehabilitation part of things, but a proper neurorehabilitation facility has basically speech therapists, they have a physiotherapist, there's robotic arms that helps in movement, basically limb physiotherapy, and it's something that is not quite yet available in Trinidad, at least not fully. There are bits and pieces, but not a full neurorehabilitation center.
All right, Josh, let's take more feedback there. Why are stroke survivors so tired after their stroke? Fatigue.
Again, because it's due to the damage to the brain.
It's a lot of damage there.
It's damage to the brain, and it takes time
it's a real lash they get.
to recuperate from that. And it basically takes time more than anything else.
It's a major event. It's a major medical event.
Yes.
There's a phrase that kind of came out of use in medicine recently in Trinidad, is convalescence.
Yes.
That people need time to heal.
Time to heal, exactly.
You could set goals and guidelines, but people need time to heal, and that fatigue after having a stroke or a heart attack is normal. They have their guidelines and their goals to get back on their feet, but we must give people a chance and time to heal.
In terms of
convalescence,
recuperation. To be honest, yes, the physiotherapist, the neurorehabilitation is really what we need for stroke patients as well. And it's either you would recover or you wouldn't. That's the reality of a stroke. And if you're going to recover, you would see improvements up to a plateau, and then you're probably not going to have anything further than that.
Okay. Any more questions there, Josh? How can I prevent a stroke? Doc, I think you can answer it before, but you can just go ahead and engage the viewer, please.
Again, manage the causes of the stroke. Diabetes, high blood pressure, hypercholesterol, so high cholesterol. So watch your diet. Make sure if you are diabetic that it's well controlled. And again, if you're hypertensive, make sure that it's well controlled.
Just to take it back, we're not talking about contusion, but a concussion. What is a concussion?
So a concussion.
We hear it in cricket sometimes.
Yeah, it's basically.
We have concussion breaks in football now, I think.
Yes. So
what
it's
happens?
A form of mild traumatic brain injury.
In sport,
where you get a hard blow to the head. There's a period of either loss of consciousness or not, but it's followed by a sequelae where you have headaches, dizziness for a period of time. But if you have a CT scan that there are no abnormalities within it, meaning no bleeds or damage to the brain, that's basically where you classify a concussion. So no structural abnormalities on the CT. If you have a structural abnormality, then it's most of the time classified as a concussion. If you have a fracture of the skull, it's classified as a skull fracture. Right? But a concussion is basically a hard blow to the head where you black out or not, and you have mild damage to the head.
Right, and the common symptoms are dizziness.
Dizziness, headaches, sometimes a bit of imbalance.
And how long could it last for?
It could last up to 8 weeks, right? But it gets better with time. Typically, within 2 weeks, you see a good improvement.
Right. I know we only have about 2 or 3 minutes left. But neck pain.
Yes.
A lot of Trinidadians suffer from neck pain. I suppose it's a little bit different from the lower back.
Yeah.
Do these people get help from a neurosurgeon?
Yes, definitely. So if you have neck pain that is shooting down the arms with weakness or numbness of the arms, it's common to have a simple term, a pinched nerve of the neck. And it's caused by a little slip disc in the neck, or a bit of both, where you have a little bit of disc protrusion and you develop spondylotic or arthritic changes to the neck, and it squeezes on the nerve. So what we do is a simple surgery where we take the disc out and free up the nerve.
You make it sound really simple.
Yeah, it's
simple. Some of us like, oh my gosh, she's operating on our neck.
It's simple. It's
but what you do is take out the disc, similar to what you do in the lower back.
Yeah. But in this case, you either replace it with a little cage filled with bone, or we also have something called a disc replacement. That's called an arthroplasty.
Is the major cause of neck pain in patients because of a disc?
Not really. The major cause really is muscular most of the times.
Right.
But nerve impingement and spinal cord impingement are very common.
Right.
So if you have symptoms of lower limb weakness or weakness of the arms, we need to see you, and we need to get your MRI done.
All right, Josh, did we leave any questions or any comments untouched? All right, you will tell me something about some feedback there. Tell me. You could probably do that off air, right? All right. So, Doc, who forms part of your team as a neurosurgeon?
So, the most important person on my team really is my anesthetist.
The anesthetist.
Yeah. I need to have someone that I could trust while I'm operating, that I don't have to worry about anything.
So the anesthetist is your best friend then?
Yes. Yes.
That's your friend who you eat breakfast, lunch, and dinner with?
So he's basically who I rely on to keep my patient well while I'm operating.
Right.
Right. Apart from that, it's a team effort. So there may be other neurosurgeons on the team. In the hospital, they are my trainees who are one day I hope are going to take over my job and my role within the hospital.
Right.
And
training doctors.
Training doctors.
Is a neurologist part of your team as well?
Yes. So I have a good group of neurologists who I heavily rely on them to manage the non-surgical.
And then speech therapists.
Speech therapists, and of course nurses. Proper nurses to manage my patients after.
Right. So it's a team effort.
It's a very much a team effort.
Right. Doc, we've come to the end of the program. I would just like to thank you for coming on tonight.
Thank you.
I suppose you presented the information in a very, you made it sound really simple, as brain surgeons do. We know it's complex work. I like the ability to express the particular stroke patients, because sometimes stroke is something that people just totally give up on. Patient get a stroke, or somebody getting symptoms of a stroke, and suddenly the whole community, whether it be doctors or patients, whoever, everybody giving up.
Yes.
But your message of get into the hospital, we could get you really back to normal as best as possible. That's a really valid message.
Yes.
And I really like that. And the message about coming in as well with headaches and getting your scans done. If anything bad, we could fix it.
Yes.
And that's neurosurgery is safe surgery.
Yes.
I think that was very important as well.
Yes.
All right. Any final words, Doc?
Well, I think in what you said there, neurosurgery in today's medicine and today's world is safe surgery, and we're trying to develop it where we make it even safer.
Yeah.
Right. And the days of having patients have adverse outcomes is more or less frowned upon. It does happen, I'll be honest, it does happen, but it's not as common as people think it is.
All right, cool. Thanks a lot, Doc.
All right.
Thanks a lot. All right, guys, so thanks very much for joining us tonight. Thanks to Dr. Ramnarine again. It was a great show tonight. Thank you for tuning in. Thanks to Josh for helping us produce this show tonight. And we'll see you again next week, guys. So take care of yourself. God bless. Have a pleasant evening and take care of yourself. Goodbye, everyone.